Excellent. Well, good morning. All of you look very bright-eyed for this early morning session. It's a great pleasure to welcome you to this poster spotlight on CDK4/6 inhibition, which of course is a hot topic at this year's San Antonio. I'm Lisa Carey from the University of North Carolina. I'm very pleased to moderate this session. We have fantastic discussants. Please, these posters are fabulous. Send your questions. You can either come from the mic or send them online. We will have the discussions for about 15 minutes, and we have about 15 minutes for Q&A. So, come bring them, challenge our wonderful presenters and our discussants. So right now, I would like to invite to the podium Dr. Wiskinski and the lead authors, the presenting authors for the first 5 posters. So that would be Dr. Xu, Rugo, Wortelboer, and Shom Goel. Carey, take it away.
All right, good morning, everybody. I'd like to start by thanking the organizers for inviting me to discuss these abstracts on CDK4/6 inhibitors in metastatic breast cancer. Here are my disclosures. I'm going to be discussing 5 abstracts that cover topics ranging from novel CDK4/6 inhibitors for treatment for metastatic breast cancer to real-world outcomes. And then we're going to focus on health-related quality of life. And lastly, talk about trilaciclib for myelosuppression prevention with chemotherapy in triple-negative breast cancer. So we're going to kick it off by talking about DAWNA-2. DAWNA-2 was a phase 3 study of delpaciclib in patients with treatment-naive metastatic breast cancer who are randomized 2-to-1 to delpaciclib with a nonsteroidal AI versus AI alone. Patients were followed for progression-free survival, the primary endpoint. The investigator-assessed PFS was significantly improved in this study from 19.3 months to 33.4 months, with a hazard ratio of 0.56. The PFS benefit was seen across menopausal statuses, as well as those with or without visceral metastases. There was also a delay to chemotherapy noted, and overall survival was not mature. In terms of adverse events, you can see, especially focusing in on the grade 3 or higher events, that cytopenias were common, including neutropenia, anemia, and thrombocytopenia. QT prolongation and AST elevation were also noted in about 4% of patients. Now, before I discuss this abstract, I'm going to present a second abstract, and this is a real-world outcomes in first-line setting. So to date, we have no head-to-head studies comparing the CDK4/6 inhibitors. P-Verify was a retrospective comparative effectiveness study looking at the Flatiron Health database, which pulls EHR data abstracted from about 280 US sites. This looked for patients who were treated with first-line CDK4/6 inhibitors with an aromatase inhibitor from 2015 to 2023. The primary analysis was for overall survival using Kaplan-Meier estimates that were both unadjusted and adjusted using standard methodologies. Palbociclib was prescribed in about 6,800 patients, ribociclib in about 1,300 patients, and abemaciclib in just over 1,000 patients. And you can see that the median follow-up was also different in these cohorts, with palbociclib being significantly longer. Now, there was no difference noted in overall survival, both in the unadjusted overall survival as well as with adjusted methodologies. Now, there are some limitations of this analysis, including that those ribociclib and abemaciclib cohorts had smaller numbers and shorter follow-up. And the point estimates were relatively unstable or possibly unstable after 30 months. And as always with real-world analyses, there's potential for unmeasured confounders. So let's put this in context of the other phase 3 studies in the first-line setting. So the primary endpoint of each of these phase 3 studies was progression-free survival, and all demonstrated benefit, whether it was with palbociclib, ribociclib, or abemaciclib. And the hazard ratios were quite consistent among these studies. So if we add DAWNA-2 to this table, you can see that it had an absolute benefit of progression-free survival that aligned with the other studies, and a hazard ratio that was very consistent as well. Now, we don't have our overall survival data from DAWNA-2, so we can't compare that. But I think it's really important to look at those results and put it in the context of the P-Verify study. So median overall survival has been improved with the addition of ribociclib in both a clinically meaningful and statistically significant way. Palbociclib did not demonstrate any benefit in terms of overall survival, and abemaciclib demonstrated a clinically meaningful benefit, but not statistically significant. One of the most notable things that I think comes out of P-Verify is that in this real-world analysis, the median overall survivals actually were quite consistent with what we had seen in those first-line studies. You can see that each of the month point estimates are very similar. And again, in this real-world analysis, there was no difference in overall survival seen. Now, beyond thinking about survival and PFS, I think that the toxicities of these agents are really important to consider. And delpaciclib, we're going to point out, has higher rates of neutropenia, anemia, and thrombocytopenia than compared to the other three available agents. And QT prolongation was noted in about 4% of patients that was grade 3 or higher. So overall, DAWNA-2 demonstrated improved PFS with delpaciclib. There's no overall survival data yet, and it does not have lower toxicity from a cross-trial comparison. So at this point in time, there's no reason to select delpaciclib over approved agents, although the first-line use is supported in those areas where it is the main CDK4/6 inhibitor currently approved. P-Verify suggests that there's no difference in overall survival among the first-line CDK4/6 inhibitors. And this would align with that PFS data that we have from those first-line studies. But the statistically significant benefit in overall survival from those studies has only been seen with ribociclib. And I really think that longer follow-up will be really valuable from this real-world analysis. And although real-world analyses have limitations, it's unlikely that we'll ever have a head-to-head study. And I think these types of studies really do add to the information in our field. Now I'm going to pivot to the second line, and this is Tiffany. This was a study in patients with previously treated metastatic breast cancer with first-line endocrine therapy alone, and then were randomized to get fulvestrant with placebo or fulvestrant with tembrociclib. This patient population was about 60% postmenopausal, about 85% had one prior endocrine therapy, 75% had secondary endocrine resistance, and about 20% had one prior chemotherapy. The investigator-assessed PFS was significantly improved from 5.6 months to 16.5 months, with a hazard ratio of 0.37. There was benefit across subgroups, including those with primary or secondary endocrine resistance and with or without visceral mets, and the response rate was higher as well. Median overall survival is not mature, and when we think about adverse events, the grade 3 or higher events were relatively low with this agent, with 5% diarrhea, about 12% anemia, and 12% hypokalemia. So let's put this in context of the other studies in this second-line setting. So palbociclib, abemaciclib, and ribociclib have all demonstrated an improved progression-free survival after first-line endocrine therapy, with hazard ratios that, again, are quite similar. And if you add in Tiffany, you can see that the absolute benefit of 10.9 months may appear a little longer than what we had seen in those other studies, and the hazard ratio may be a little bit better, but again, you have to be cautious with cross-trial comparisons. There's no overall survival data yet from Tiffany to compare. So now looking at adverse events, you can see that overall this agent is relatively well tolerated from terms of side effects. There are lower rates of neutropenia, although a little bit more significant rates of grade 3 or higher anemia, as well as hypokalemia, and diarrhea is kind of in the middle. So fulvestrant with tembrociclib improved progression-free survival in patients with prior AI and no prior CDK4/6 inhibitor, and that absolute PFS improvement and hazard ratio overall looked promising. But the overall survival data is not mature, and I think overall this had a good safety profile. But I think one of the key questions in my mind is, do we know that this is maybe more active than any of the current existing CDK4/6 inhibitors? Could it be sequenced after them? But probably even more importantly, how do we position this, as well as the current existing CDK4/6 inhibitors, with some of the newer drugs that are in development? So the current agents are ATP-competitive inhibitors of CDK4 and 6, and so this causes G1 cell cycle arrest. And there's some data that the CDK4 inhibition may be more important for cell cycle arrest, whereas hematopoiesis may be mediated by both CDK4 and 6. And so the ratio between those two for any individual drug may balance efficacy and toxicity. There's also emerging data that resistance frequently occurs through activation of CDK2. So there are multiple compounds in development targeting this pathway, including selective CDK4 inhibitors, inhibitors of CDK4, 6, and CDK2, and cyclin D PROTACs. And as these medications come into our field, I think we're going to have to learn a lot about how the current CDK4/6 inhibitors compete with those. Furthermore, we've had a significant evolution in our treatment of hormone receptor positive, HER2-negative breast cancer in the last few years. And we often start with endocrine therapy with a CDK4/6 inhibitor, but now, just in the last few weeks, with inavolisib approved, we have fulvestrant and palbociclib with inavolisib in patients whose tumors have a PI3 kinase mutation and have early recurrence. Genomic testing is incredibly important to make decisions in the second line, where we can think about agents targeting the PI3 kinase AKT pathway, like alpelisib and capivasertib. We also have patients with ESR1 mutations, where we think about elacestrant or other new SERDs, ERB2 mutations, where we think about neratinib. And then even for those with no actionable mutation, you can switch endocrine therapy and add in everolimus, or think about another CDK4/6 inhibitor based on the maintain and post-monarch data. After progression on second line, you have to think about whether the patient's a candidate for third line therapy. If they are, you have all the options above. And if they're not, you have PARP inhibitors, ADCs, and chemotherapies available. All right, now I'm going to pivot away from this topic and think a little bit more about health-related quality of life with the CDK4/6 inhibitors. This is analysis of the SONIA study, which I'll remind people was either giving CDK4/6 inhibitor with an aromatase inhibitor in the first line or in the second line with fulvestrant. PFS2 was the primary endpoint of this study and was not statistically significantly different. Now, this was a fairly endocrine-sensitive population, with 86% being postmenopausal. Primarily, patients had either de novo disease or a prolonged disease-free interval from their adjuvant therapy, and palbociclib was chosen as the CDK4/6 inhibitor in 90% of patients. A key secondary endpoint of this study was quality of life, with FACT-B assessments at multiple time points, both during first-line and second-line therapy, as well as at the end of treatment. Survey completion was incredibly high in this analysis, and there was absolutely no difference in health-related quality of life seen, with close to zero average absolute differences in FACT-B scores as well as subscale scores. And this is despite 42% more grade 3 or higher AEs being reported in the study and a tripling in CDK4/6 inhibitor duration with first-line therapy. Now, this may be that patients had low symptoms at baseline, but it also is really concordant with the data that we saw out of PALOMA-2, where FACT-B time to deterioration was not different between those studies. And I think that this may also be that palbociclib overall has a relatively low toxicity profile. You can see grade 3, 4 events are quite uncommon, especially in those symptoms that impact quality of life. And even those that are grade 1, 2 are usually fairly manageable and low rates. So overall, health-related quality of life is incredibly important for us to be looking at in metastatic breast cancer, especially as we're seeing overall survival improve and prolonged durations on therapy. And SONIA indicates that there may be a population who could defer CDK4/6 inhibitor to the second line with no compromise in PFS2 or health-related quality of life. However, this was a very endocrine-sensitive population. It's really unclear if these results are applicable beyond palbociclib. And we do have first-line data with ribociclib improving overall survival benefit and abemaciclib having this clinically meaningful benefit. So we really need to understand, does waiting to the second line with the CDK4/6 inhibitor continue to maintain that overall survival benefit? So lastly, I'm going to talk about PERSEVERE-2. This was a study with trilaciclib. And in this study, the CDK4/6 inhibitor is being used to reduce myelosuppression through proactive protection of the hematopoietic stem and progenitor cells. This was triple-negative breast cancer, first line, treated with gemcitabine and carboplatin, given trilaciclib before chemotherapy or a placebo. Overall survival was the primary endpoint. And you can see here that there was no improvement in overall survival. There was also no difference in PFS or response rate. And this is despite myelosuppression being reduced from 28% to 8.3% grade 4 myelosuppression and less need for G-CSF. So to me, this really calls into question about how much does dose intensity matter in the metastatic setting. For neutropenia, we can think about dose modifications and reduce intensity, or we can try to maintain intensity with G-CSF or other agents like trilaciclib. Previous studies have shown no overall survival benefit from dose intensity with chemotherapy in the metastatic setting, including with Q2-week versus Q3-week FAC, as well as a single institution experience. Now, there are limitations of these studies, but I think it really calls into question whether dose intensity matters. And I think we do dose modifications for patients' experience on chemotherapy too, right? Gemcitabine carboplatin, about a third of patients in a recent study had to discontinue one of the agents. And part of that was for cytopenias, but a lot of it was because of symptomatic side effects. And so dose modifications have other intentions as well. So overall, NCCN states when the intent of chemotherapy is palliative, G-CSF use is a difficult decision and requires careful discussion. And I think that this aligns with my conclusion from this abstract, which is that trilaciclib did not improve overall survival and should not be recommended. So I'm going to end by thanking the poster presenters and the session organizers, the participants in each of these research studies, and then my colleagues at the University of Wisconsin who helped me in preparation for this talk.
Thank you for that fabulous discussion. Do we not have a seat for you? Oh, I was like, I'll make you stand up the whole time. Okay, this is open for questions. There are microphones scattered, and you can also put questions in online if you'd like. I have a question for the collective audience here, the speakers. You know, as our CDK4/6 inhibitors get better and get used more frequently and get used in varying lines, and in the next session, next group, we'll hear some, ways to maybe predict, for use of them. PFS, so Sonia had to go to PFS too and it ended up being not really mattering. The Dana trial, they used, and several other trials have used as an endpoint, time to needing chemo. So basically a measure of time to reaching endocrine resistance. As we have all these increasingly effective, endocrine after endocrine, adjunctive therapy after adjunctive therapy, do we need to change our endpoints for these trials and focus more on that kind of an endpoint, or are we realistically gonna get much out of PFS1? Carey, you get to answer that first, and then Hope. I'm gonna call on people if you don't volunteer.
I think it's a really good point. Time to delay of chemotherapy is incredibly important for patients' experience, right? Especially because these agents are incredibly well tolerated overall. I do think we have to think about our regulatory bodies and would they approve based on endpoints such as that. And we really have to understand still the impact on overall survival. I think we shouldn't forget that that is really our ultimate goal.
Yeah, I think that as we have more and more effective therapies, not just with endocrine therapies, targeted agents, and now antibody drug conjugates, we're really faced with big decisions about sequencing and what order we need to give our therapies in. For example, I think, Destiny Breast 06 brought up the question of when we give an antibody drug conjugate versus chemo versus endocrine therapy. And when we saw in the rapid presentation by Aditya Bardia that, maybe the patients who have a very short response in first line should go on to an antibody drug conjugate as opposed to standard chemotherapy. But is overall survival really the end of what we're looking at, given the no differences in quality of life starting a targeted agent first or second? It does seem as though, the regulatory agencies really want to look at overall survival, but we highlight the disparities in access to drugs by looking at overall survival rather than looking at PFS1 and 2. So I think PFS2 is a critical endpoint, and it's going to be really important as we look at some of the trials like Serena-6 that are looking at ESR1 mutations to drive a change.
Well, it ends up being PFS3, and maybe, et cetera. Yes?
Yeah, I think indeed, of course, overall survival and quality of life are the things that patients matter the most. And but it's quite hard to wait, for example, for overall survival results of all the studies. So I think PFS2 already captures more and is a better surrogate compared to PFS1. So more sequencing trials and especially crossover, like 100% crossover in trials, should be a way to determine the sequencing of new medications.
Shom, in the trilaciclib study, I think among the take-homes to me, and you should tell me if I'm misinterpreting, you did see a cytoprotective effect of the CDK4/6 inhibitor, but it didn't end up mattering very much. And I think for many of us, this gets back to the move towards kind of rationally deriving treatment dosing, right? Because as we all know, we get to our doses by, going to maximum tolerated and then going down one, right? Which is not biologically driven. It's maximum tolerated dose. And so I think this does lend, in this setting where you're using MTDs and then backing off, it didn't matter very much, but is it, you do use fewer growth factors, patients may feel better, et cetera, et cetera. What do you think the future is for CDK4/6 inhibitors in this particular setting? And do you see, as we're trying to moderate our doses of chemotherapy, do you see a role here? Because this was a swing for it phase 3 that did not meet its endpoint.
Yeah, thanks, Lisa, for that question. So I think it's worth pointing out, yes, the primary objective of the PRESERVE-2 study was overall survival. But the rationale for that was not so much that we thought by being able to deliver more chemotherapy or better doses of chemotherapy that we would prolong survival. The rationale was based on the idea that CDK4/6 inhibitors would actually stimulate an anti-tumor immune response so that the drug itself would have a direct effect on killing tumor. And that was supported by a large amount of preclinical data from laboratories all around the world, and our sort of hopes were boosted by the results of a randomized phase 2 trial, which was published by Dr. Tan in the Lancet Oncology, very similar design, where overall survival was very significantly improved with the addition of Trila to this exact chemo backbone. Hazard ratios in that study in the 0.3 to 0.4 range. So obviously, these results were disappointing for us. The results of the randomized phase 2 were not recapitulated. The fact that we saw some improvement in myelopreservation with Trila, less neutropenia, a little bit less GCSF, is consistent with what's known about the drug and how it can act. But in my opinion, the magnitude of the myelopreservation effect seen in this study is small, and it's not really justifying sort of the use of Trila in that context for triple-negative disease.
Fair enough. Hope, this is a question for you, and there's actually several that I approved one of them that sort of puts it all together. In the setting of the real-world evidence, and yours is big, I mean, it's almost 10,000 patients that didn't see much of a difference across them. There's been a narrative after, there was a survival advantage in cross-trial comparisons with Ribo, a suggestion with Abema and not with Palbo. Do you think this sort of lays to rest the concern that you should not be choosing Palbo, which I think was what people were taking away, given the real-world evidence? And just remember, everybody, there's like several Palbo trials, and we're about to hear one in ER-positive, HER2-positive in the general session. So can you speak to that? What's your takeaway?
I think the accumulated data does make me feel as though this highlights the differences in trial eligibility, timing of trials, sequencing of agents. There are just so many different aspects that impact eligibility. The patients you happen to have enrolled. I think there are so many things that influence our enrollment in trials, and we're not doing a whole bunch of genomic sequencing before patients go on these trials to start with either. And this is a really big real-world analysis. We did sensitivity analyses to look at the later approval date for the other two CDK4/6 inhibitors and still saw no difference. And I think in light of all of the data, we have the PADMA study, which showed that giving an AI or any choice of endocrine therapy with Palbo was better than chemo with a really marked difference similar to what we saw in Right Choice, but you didn't have to give combination chemo. So it was more in line of what we do in chemotherapy as first-line treatment. And then the data on post-Monarch and now EMBER-3. So you could see that you could give sequence CDK4/6 inhibitors and have an improvement, at least as far as we know now, progression-free survival over single-agent endocrine therapy in the second-line setting. And I think all those data combined really do lay to rest, to me, that concern.
Well, and a follow-up also, there was a series of questions that relate to the sequential use of CDK4/6 inhibitors. And, as a collective group, do we believe that CDK4/6 inhibitor after CDK4/6 inhibitor has enough data, and do you all feel comfortable doing it?
Yes.
You start.
Okay. I think we now have 3 trials that have shown that there's some efficacy in this setting, so that in a patient who doesn't have a biomarker that we're specifically targeting with a tolerable agent, this is something that I think we all have liked to move away from giving a naked endocrine therapy, so a single agent endocrine therapy. Even in the ESR1 mutant population, I think being able to do combination therapy, if it can be tolerable, is very appealing. And if we can improve the time on oral therapy and delay time to chemotherapy, as we talked about earlier, that's a win for our patients.
Yeah, I want to add on that. I think indeed improve time on chemo and on endocrine therapy, but also improve time on endocrine monotherapy for the patients who can do that. Because in Sonia we see that in general patients there's no difference between the 2 treatment lines, and we can defer it to second-line treatment. And there will be patients that perhaps will benefit from first-line treatment, but we are still looking to biomarkers for that. So I think in sequential design of CDK4/6 inhibitors, perhaps there will be patients, but we still have to figure out which patients that are. Yeah.
Okay. Other comments? And by the way, those of you who are in the audience, I know this is not a shy crowd, so please come to the microphones and join us. Shom?
Yeah, I agree with the previous 2 speakers that the data now has accumulated to a point where I would feel comfortable with CDK4/6. I think it's most compelling for abemaciclib at the moment, post CDK4/6, and I agree with Hope's comments that I would prioritize that approach in patients where there's not another obvious genomic biomarker to suggest a different treatment.
I couldn't hear everybody, but I also say that I think the most of our data has really been after palbociclib, so I do think we still need more information after prior ribociclib or abemaciclib in the first line.
Yeah.
Which I think I was just thinking that that's a really important point. Like, was it all just post-palbo? But it's actually now we have an accumulated group of patients in post-Monarch and EMBER-3. You also had ribo, tiny number of patients with abema. But it's a fascinating idea that, continuing CDK after CDK seems to be effective across even biomarker subsets.
Well, it at least gives you support in your patients who got adjuvant CDKs that you shouldn't then avoid using them. And of course, all of our algorithms are going to get blown up by the now cohort of patients coming through that are not reflected in these trials who got CDK4/6 inhibitors during their adjuvant phase.
And I think that's an incredibly important point for all of us, is that having the CDK post-CDK is the primary data we have moving forward about what to do with patients who still have endocrine-sensitive disease but received an adjuvant CDK4/6 inhibitor. I think that with the accumulated data we have now in the metastatic setting, we can choose the right drug for the right patient. So based on the patient's clinical characteristics, tolerance of drug, we can really improve quality of life by taking the right approach. And maybe there will be a patient where you want to not give single agent endocrine therapy. We don't do that much except for in people with massive problems, but because we want to do the sequencing. And I think that's one question that Sonia can't really answer, is if you continued the CDK in the second line or changed, would that have improved outcome?
Right. Well, and the Sonia approach is terrific. Yes. If we could identify the really endocrine sensitive ones, the control arm did really well. Doctors chose carefully and appropriately patients to put on that trial. And the other problem that we have is if you delay, then suddenly you have a pile of drugs and options all in the second line. And then you have to start, you have no algorithm. You have a dog pile on the second line setting, which is, I think, troublesome.
Yeah, I think one thing to add is that we published the Sonia 2 weeks ago in Nature, and there's also about the subsequent treatments after the 2 lines in Sonia treatment, and those patients really get this similar treatments after the 2 lines of treatments. So I think, that there is no reason now that those patients should be treated differently.
Well, it's a lovely trial. Congratulations. Congratulations to all of you. Thank you, Dr. Wiskinski. And we're going to move to the second half of the poster spotlight.
This is not your phone, right? This is her phone.
No, that's my phone. Okay, good. Thank you for. Dr. Goetz, you have the bar is set very high for you. So if Dr. Liu, Shatini, Brufsky, Nader-Marta, and I think Dr. Tang on behalf of Dr. Lau, come on up and join us. And Dr. Goetz will be the discussant for this second half. And all the questions we identified in the first half are going to get addressed in this half.
All right. Well, thanks, Lisa, for the opportunity, and to the organizers for an opportunity to discuss these very interesting abstracts today. So these are my disclosures. Okay, so these are the posters that I'm going to discuss today. So the first one is Dr. Yen-Shen Liu, who is doing a secondary analysis of the Right Choice clinical trial. Many of you are familiar with this. We'll go into the details of this. Dr. Isabel Garcia Frutoctos, looking at intrinsic subtype switching at progression in patients treated with CDK4/6 inhibitor. Dr. Brufsky et al. Looking at mammaprint with gene expression in association with RB loss genes or the RB signature. Dr. Nader-Marta, secondary analysis of the PACE trial. Then finally, Dr. Lau, looking at a new biomarker, ctDNA, in a cohort of patients treated with metastatic breast cancer in China. So here's the outline for what I would like to discuss today. I'm going to talk about what is the optimal approach for performing biomarker studies. We're going to talk a little bit about the fluidity and evolution of biomarkers across disease settings and drug treatments. I think this is probably one of the real major take-home points that I want to make. And the importance of the fact that these biomarkers have different prognostic effects in the endocrine sensitive and resistant setting. Intrinsic subtypes, we've obviously been well aware of these data with endocrine therapy in the adjuvant setting, but now we're beginning to look at intrinsic subtype in response to CDK4/6 inhibitors. So this is actually some exciting data. What's the role of the RB gene signature and its correlation to clinically available gene signatures? And then finally, in the clinical setting of progression on CDK4/6 inhibitor, are there biomarkers that can identify patients who benefit from continuation of therapy? So I decided today to take a real different approach, perhaps, than maybe what people have done in the past for this, but I want to go back. And I think sometimes when you're new in the field, maybe you're just out here a few years, you forget about some of the giants that have come in the past. And so this is a really important paper that none of us would ever have thought about thinking about in the metastatic setting. Why? Because in the metastatic setting in the past, we ran trials, let's say, testing hormonal therapy, and we never collected biomarkers. And now in this new era of CDK4/6 inhibitors, where we are following patients for up to 5 years, all of a sudden collecting biomarkers and doing it well is critically important. So we're going to go back, and I guess I'm going to channel my inner Dan Hayes here. And this is an important study looking at the use of archived specimens in evaluation of prognostic and predictive biomarkers. And this was really focused on the use of archived specimens in the adjuvant setting. So many of you are familiar with this, but many of you may not. So what did Rich Simon, Dan Hayes, and Soon Paik talk about? Well, they developed a framework for performing biomarker studies. And they identified these different categories. Well, let's go through that. Category A, a prospective clinical trial designed to assess the biomarker. Specimens are collected and processed and assayed for a specific marker in real time. Obviously, there's many examples where a biomarker has been tested in the adjuvant setting. Category B, a prospective trial not designed to address the tumor marker, but the design accommodates tumor marker utility. Accommodation of the predictive marker requires a prospective randomized controls trials. This is important because we want to be able to answer the question of, is this biomarker not just prognostic, but is it predictive? There's some important things about this. The specimens need to be collected, processed. They need to be archived prospectively. There needs to be SOPs. You actually have to have enough of the specimens. You can't, you have to have, generally, the recommendation here is greater than 70% of the specimens. And then up front, your study has to address the therapeutic question, and you have to have a statistical analysis plan. So now we need to start thinking about applying these rules in the metastatic setting as we're looking at biomarkers. Here's category C, a prospective observation registration trial. This is just a registry trial, and specimens are collected. They may be done well, but the study is not prospectively powered. And then, of course, category D was a retrospective observational study with really perhaps the specimens were collected at convenience. So I like to think of it this, when I think about the analysis, the PAM50 analysis of the Mona Lisa study that was conducted by Alex Pratt, I like to think of this as coming in line with very close to category B. Now, it didn't quite make it, and I'll tell you why, but this is a very important study that looked at the role of intrinsic subtypes in the analysis of the Mona Lisa phase 3 trials. And as you know, what was found in this study was indeed the intrinsic subtypes were prognostic, but importantly, as you can see, it's this basal subtype, a relatively small number of patients, which is really gaining no benefit from the CDK4/6 inhibitor. So as we think about that study, one of the things that I'm going to point out was the whole issue of, well, do we need to collect our specimens at the time of the diagnosis of, in this case, of metastatic disease, or maybe we can use a biospecimen from 20 years prior. And I hope I'm going to try to convince you today that actually we need to be collecting biospecimens at the time that the patient is diagnosed, at the time that the patient goes on to study, and because of the incredible fluidity of these particular biomarkers. And this was actually shown here by the same group, Dr. Alex Pratt's group, in a publication in 2017, when just comparing the primary and the metastatic, and what you saw was that the basal subtype is actually really quite stable. You don't go from basal to luminal at some point, but actually it's these luminal A's that switch to luminal B, and many of the, you can see 40% of luminal A is converted to luminal B's, and about 14% of cases of luminal A is converted to HER2 enriched. So this fluidity is going to be very important, and that's why you don't want to be taking a biospecimen from a primary tumor collected 20 years prior and then correlating that biomarker, whatever that is, with outcome in a metastatic trial done, many years later. What about context specific? So this is also a really important point that I want to make. We know that PIK3CA mutations are prognostic. People have shown that. But the interesting thing is that PIK3CA mutations have a different prognosis in an endocrine sensitive versus an endocrine resistant setting. This has been shown by Shireen Loy. It's been shown by many different people that in the first line setting, that PIK3CA mutations in an endocrine sensitive tumor are associated with better prognosis. But we know that there's a switch. And here's an example just from the Monarch studies where the PIK3CA mutations were prognostic in the letrozole alone arm. So this is only letrozole. You can see that 25 months for the mutant versus 14 months for the wild type. This is quite consistent with what other people have shown. But all of a sudden in Monarch 2, in an endocrine resistant setting, you can see there's this switch. Now all of a sudden the mutation becomes associated with a poor prognosis. And this is actually important now if you are mixing in samples from an endocrine sensitive and endocrine resistant and asking the question of, is my biomarker, whether it's PIK3CA, whether it's NF1 or whatever, you have to make sure that you are not mixing in samples from different settings. So the point I want to make here is there's incredible fluidity, and you better make sure that you're actually collecting the sample from the situation that you are seeing right now in that particular patient. So in light of that, I want to congratulate all the people who actually did work here, some fabulous work here. Many of you know about the Right Choice trial. This was a really important study that compared standard chemotherapy versus first-line ribociclib endocrine therapy for very clinically aggressive. Some of these patients had visceral crisis. And what we know is that the combination of ribociclib and endocrine therapy outperformed chemotherapy. So what the authors did was they did a secondary analysis of this group of patients, looking at intrinsic subtypes and also a variety of other immune markers. And what they showed was that patients with low expression of tumor inflammatory immune-related cells had more pronounced PFS benefit with ribo plus endocrine therapy. And conversely, in the chemotherapy arm, the patients with low expression of these immune-related genes had shorter median progression-free survival. So what are the strengths of this study? I think it's very important to point out this is a secondary analysis of a prospective clinical trial. So this is really what we're trying to get to be done. Some of the limitations, however, is that we had a relatively small number of samples. So there was about only 22% of the total number of patients involved. So that limits what conclusions that we can take. The other thing is just the issue of the use of archived biospecimens. And based on what I mentioned before, we really need to actually bring up and look at the biospecimens that are relevant in that particular time point. So moving on to the next poster, again, really, really important data, and this really brings home the point of the fluidity. So this particular group looked at the intrinsic subtype switching at the time of progression on CDK4/6 inhibitors. And I apologize, I don't have the key here, but one of the things that's point out is that there is really a move towards HER2 enriched, and then there's the loss of luminal subtypes. And this actually is quite consistent with what we're seeing overall. And one of the things that these authors did is actually some of these biospecimens were again collected at the time of the original diagnosis. Some of the baseline biopsies are actually from the time of diagnosis of metastatic disease. But nevertheless, I think what I want to really make sure that you take home is that there is fluidity in these biomarkers. And this is important as we think about collecting biomarkers in the metastatic setting to guide our therapy. You have to have a clinically timely biomarker to guide decision-making at the time that you actually are seeing the patient. So the conclusions here, post-CDK4/6 endocrine therapy biopsies demonstrated a shift towards less endocrine sensitive and more proliferative disease. They showed in a very small group of patients, it appeared that the PAM50 post-CDK4/6 remained prognostic. And I think here the hypothesis now coming forward is that maybe the PAM50 post-CDK4/6 can identify a subset of patients that could be treated according to the biomarker findings. And so one of the questions that comes up, of course, is the PAM50 the best biomarker? And the main issue that we see here is that when we're seeing patients in the clinic, sometimes a tumor may not be accessible. We may not be able to get a liver biopsy, or we may not be able to get a lung biopsy. And so can we actually potentially identify or use circulating blood-based biomarkers? Before I get to that, I want to briefly talk about the Brufsky poster. This is looking at the role of MammaPrint for identifying tumor subtypes that may predict resistance to CDK4/6 inhibitor therapy. Their hypothesis is very simple, very important hypothesis, that MammaPrint's risk categories that have higher correlation to gene expression according to the RB loss of function would likely be potentially more CDK4/6 inhibitor resistant. And what they found was using this RB signature, this 87 gene signature that's previously published back in OncoTarget years ago, but this loss of RB loss signature is highly associated with this MammaPrint high risk subset. And you can see the proportion of tumors that are hypothesized to be resistant to CDK4/6 in the so-called high 2. So, of course, a question might be, why not just measure the RB signature? Well, it's a little bit complex. We just did this, and these data are manuscript is in preparation in a prospective trial where we actually did the biopsies of patients with metastatic disease, looking at RNA signatures. And what we can see indeed is that RB loss signature is highly prognostic. But I think a better approach than that is actually to measure this in the DNA, in circulating DNA. And this is something that Dr. Alex Pratt and others have developed, is this DNA loss of heterozygote, or RB loss signature that has actually been generated and correlated previously with biopsies obtained, for example, from TCGA, and then ultimately developed into a DNA signature. And this, I think, is ultimately what needs to be done in the future, is to be able to develop these circulating signatures. I'm going to end here with, I have two posters left, but this is a poster by Dr. Nader-Marta looking at a secondary analysis of the PACE trial. As you all recall, the PACE trial took patients who had progressed on first-line CDK4/6 inhibitor with palbociclib, and they were randomized to continue palbociclib plus endocrine therapy or endocrine therapy alone. And there was this very interesting third arm that combined an immunotherapy, an immune checkpoint inhibitor along as well. And I think one of the take-home questions that comes out here as we begin to see that second-line CDK4/6 inhibitors, specifically abemaciclib, seem to be coming entrenched in the second-line setting. Our question is, can we use and identify biomarkers to identify which patients might benefit from continuation of therapy? So here's the questions. Are there biomarkers that identify a subset of patients that could benefit? So they asked the question, is the ctDNA 5-group DNA-DX biomarker, is it prognostic or predictive? And of course, are there subsets that may or may not benefit? So this DNA-DX signature, what is it? This is actually developed again by Alex Pratt, Chuck Peru, and others, where they actually take data from the TCGA using methylation data and ultimately try to take RNA signatures and then use DNA to actually take those signatures and then take the DNA methylation signatures and move that into the circulating setting. Because, of course, the issue here is it's very difficult to get these signatures from biopsies. And so if you could have a circulating signature, that would be ideal. And so they're now taking this DNA-DX signature that's been previously developed, and they're looking at it as a secondary analysis in this prospective trial. And what you can see here is that it appears that the luminal subtypes of patients in this secondary analysis may be the ones that most preferentially benefit from the continuation of palbociclib. So I think this is actually really exciting because now we're moving into this scenario now where if we're going to continue on with CDK4/6 inhibitors, which are the subsets that may benefit from continuation and which are the subsets that may not. So I think the thing we could take away from this, number one, is this ctDNA 5-group classification prognostic. It appears to be, are there subsets that may preferentially benefit from continuation? I think potentially. What about the DNA-DX RB LOH signature? I actually spoke to the investigators. They're actively planning to look at it, and we really look forward to those data. Finally, I'm just going to go over, this is a poster by Dr. Lau et al. Looking at a signature. This is a specific NGS liquid biopsy that they looked at in patients with metastatic disease. And so Lisa's about ready to take a hook and pull me off the stage.
Cattle prod, actually.
That's harsh, but I need to finish up. So the point that I'm going to make here is that this is a retrospective study. This assay looks quite interesting. I did want to point out a couple things that I thought were quite interesting. Number one is that even though there were a relatively small number of patients that received endocrine therapy, most of these patients received chemotherapy, it seemed like there was a relatively high percentage of patients with RB1 alterations. The other thing that I saw, which was quite interesting, was a relatively low percentage of patients with ESR1 mutations. And this, of course, these are things that we have to be looking at as we look across different ethnic groups. Do we see differences in the development of these different resistant mechanisms? So we really look forward to seeing these data in light of the clinical characteristics. So my last slide here is just the conclusions. And the metastatic setting, tumor samples that are collected decades early, I call them samples of convenience, will not provide optimal insight into the biology and drug response in the current setting. Substantial evidence to demonstrate now the fluidity and evolution of these biomarkers in their role as predictive in being potentially predictive of outcomes. There's clearly a clinical need to obtain relevant biological samples prior to studying your drug of interest. And now I think as we're getting into these studies, we need to be thinking about some of the old recommendations. I call them old, but they're 15 years ago. And that you need to be thinking about the rules for actually looking at biomarkers. And if you don't, or if you're not careful, you may miss the predictive. Prognostic biomarkers are easy to find, but it's very difficult to find predictive ones. You have to do it carefully. So my recommendation here to end is please follow Simon et al. Use of archived biospecimens in the evaluation of prognostic and predictive biomarkers. Thank you.
That was a terrific discussion. Thank you. Thank you so much, Matt. So again, we have the microphones are open. I think I'm going to ask a question partly of Matt and partly of Dr. Tang. In your poster, you found tumor fraction, which to some degree is a measure of burden, right? So, and many of these ctDNA and blood biomarkers are being used in that way, right? You're looking in aggregate. But the truth is that I think as we're moving into increasingly targeted approaches for the next line decision making, does your assay allow the kind of phenotyping that like the DNA DX does? Because it's almost like you want both of those. You want something that tells you something about essentially the nature of the cancer as well as specific ESR1, for example.
Yes, I think first it's a very good question. So this is we call it a comprehensive genomic profiling. We use 152 gene assay. So the tumor fraction code is based on frequencies of the mutations, and we did detect some fusions. Frequencies we design them to calculate tumor fraction, and we also because 152 so do kind of subtype for those patients based on their genetic. And we did find fraction alone maybe not enough. So you ask the question, did we have the tumor fraction? So have those blood samples after treatment. So you can do two things. The tumor fraction has reduction for the treatment. You can see the subtyping after treatment. Does the treatment change the subtyping, molecular subtyping? It's a very good question to know, and we can do some testing poster next year.
Back on us. Microphone one.
Presentation. My question is, Ravsky's poster, I can't remember the number. When you mentioned that are switching to proliferative tumors, they are high risk, more basal-like histology. Can you comment on luminal tumors? You're seeing this phenomenon. What is that associated with RB loss, or these patients differently?
So I'm not quite. So you're asking if there's a switch question?
So luminal tumors that are switched, let's say basal histology, is that a phenomenon? Do you also see that in luminal A? Tumors tend to be a little bit more high risk in radar cases.
So I think there's a lot of data that neoadjuvant setting that there's a it's pre-existing, it's not switching. So in other words, whether A or B, about 20% of the luminal by immunohistochemistry, when we look at with intrinsic subtyping, a little bit different than PAM50, about switch to a basal phenotype or typing. So they already exist. It's not necessarily actually reclassifying them. And I think we see the same thing as well.
You're talking about in the same tissue, not,
the same
not
tissue.
so,
Correct,
not,
not down. It's not that. So classifying existing tissue. It's not a, I think is kind of what we're talking
Do you
about
have mammoprint data about, what happens, primary met comparisons?
No, we do not.
No, okay.
Time of metastatic disease, if you noticed any swing.
Metastatic samples. This is all early disease.
Well, there's, that is directly, thank you, relevant to any of you, are there any biomarkers, tumor, that would make you not CDK4/6 inhibitor plus endocrine therapy as a metastatic setting? Start with Matt. Say, nope, not going to do it, I'm going to chemo.
First line metastatic setting, really the only biomarker is, is ER, right? So if you have a ER negative, of course, that is the that we use. If about some of these additional biomarkers that are about, an RB signature, this is clearly not. I think where we hope and what we want to do in the by those tumors that have intrinsic subtypes. We've seen some data from, in the adjuvant setting as being a potential biomarker, but we're not there as of yet to be able to and say, gee, you shouldn't get this drug.
Anything to add? Pardon? Are there any biomarkers that would make you say don't get CDK4/6 in the first line setting? Right now.
Yes, actually, we gene copy number loss cohort and such as ATM, and I want to apologize because due to the limited cohort, we did find more gene mutations except for ATM. They have relatively higher p-value, so our cohort to see if there are any gene variation, and they are not suitable for CDK in our cohort.
Who's next? Up. Yeah.
Yeah, I think at the first, it's difficult. We don't have very good use. I think we're bringing that more and more to the first line. We used to have only ER. It's still the most important one. Now we're bringing PIK3CA alterations to the first line settings too. So trying to bring personalized medicine also to the first line. But it's hard at the beginning now to know, even with clinical characteristics, we sometimes assume patients are not going to derive significant benefit, but still we don't have biomarkers that are good enough upfront in the first line setting to say these patients shouldn't receive this treatment approach, I think.
Okay.
In our poster, we have a very interesting finding that even though it's only 50 patients only, but we study in 700 immune-related genes and found that if in the baseline, the immune score are relatively low, then patient will enjoy a very, very long disease control with ribociclib. But if the baseline immune score are relatively hot, then the median PFS will be down to 1 month, 1 year, sorry. But on the contrary, if you apply combination chemotherapy, they have opposite role. Even though there's opposite, it doesn't mean that they will be much better than ribociclib. Just as we all know that in the original trial, ribociclib is better than combination chemotherapy. But in the data, that if the tumor are originally hot, then, well, I guess that the data will be relatively equivalent in chemotherapy versus ribociclib in our data. I think it's brand new marker to tell that who will benefit more or less to CDK4/6 inhibitor. Because before, there's tremendous effort try to find any kind of markers, but just failed. But we just have this quite interesting data. And probably you will consider that it's a small number, but I just have a conversation with another expert, and she just told me that in her homemade data, have an identical observation with us. So I think for this observation, it will want to further explore to confirm.
Thank you. Microphone 2.
Oh,
Oh, sorry. I'm sorry, Adam. I'm just
Go ahead,
I'm
go for it.
mindful of the poor guy standing there.
go
Go ahead.
Thank you so much. Patrick Nevin from Leuven in Belgium. Some endocrine treatments have a long half-life. So if a patient, for example, is progressed on fulvestrant, when do you take the biopsy for biomarkers? You have to take a washout period into account? Or is there no effect of fulvestrant still being in the body for several weeks and months? Does that affect your biomarker assessment?
Francesco, I'm going to let you answer that one.
Well, in general, to organize a tumor biopsy at progression from, for example, CDK4/6 inhibitor is not easy to do that right at the progression. So we need some time that we can use as a kind of washout time. And we usually perform the biopsy within a month, which means from 2 weeks to 4. Ideally, we would like to have the biopsy as soon as we can get it because we need to treat the patient. So, and that's also one of the limitations of this kind of approach, that we have to wait some time to get the biopsy. So we need fit patients. We cannot do that on rapid progression. So your point is a great point, of course. There is necessarily some washout time. And in general, in the first line, we use aromatase inhibitor more than fulvestrant, I would say. So.
Okay. Thank you so much, everyone. I'm afraid we are at time. And so please feel free to come talk to your poster presenter of your favorite one as they are up here, and enjoy the rest of the day. We're going to have a fantastic talk from Melissa Davis right now, and then the general session. Have a great day.